Uh, thank- so welcome everybody to the first of four sessions relating to this topic. I'm Judith Feinberg. I'm an infectious disease physician by training, and I have been doing education, care, and research into these viral illnesses for decades now. So it's my pleasure to join you today. I should also note very importantly for all of us here in West Virginia that I am the chair of the state task force for the elimination of hepatitis C and HIV, and I hope you're all going to be an important part of that. Okay, here we go. I have no disclosures. These are the objectives, but in the interest of time, I'm gonna jump right past them. And by the way, the slides will be available to you from the ECHO staff. So let me just start by saying that there's similar risk factors for HIV and hepatitis B and C. Here in West Virginia, these days, injection drug use is our primary problem, but unprotected sex is uh, is probably the second most important factor. And let's start with hepatitis C. So here is a slide that shows a heat map of the United States in terms of the maternal hepatitis C prevalence per 1,000 live births. This is on a county level. And you probably did not need me to put that red box around Central Appalachia, but you can see that this is clearly the most heavily affected area in the country. And here is a 10-year retrospective study that looked at all of the births in the United States and then those that occurred to women who had hepatitis C. And over this 10-year period, the rate of hepatitis C infection more than doubled. And you can see on the right-hand side that women who are white and American Indian or Alaska Native Indigenous populations have the highest rates. And in the next slide on the left, you can see that women without a four-year college degree and women who live in remote rural areas or rural areas that are adjacent to more populated areas are the places where most of this hepatitis C infection is happening. And here specifically is data from a 5-year study about hepatitis C in pregnancy in West Virginia. It's a retrospective study, and they looked at the antibody positivity rate, and it was almost 12% per 1,000 live births. So what does this represent? Just a few years prior to this, in 2014, the positivity rate was 1/5 as much in West Virginia. And then if you compare the current rate to the rate for the entire United States, then you see that the rate in West Virginia is 35-fold. That is spectacular, folks, and really a sad reflection of our terrible drug epidemic. And then to verify the individuals who were actually had chronic hepatitis C, which we do by looking for hepatitis C RNA, we could detect it in this study in about half of the patients. So over 6% of the women who were screened, so this isn't all the women, just the women who were screened in this 5-year period had chronic hepatitis C and were therefore in a position to be able to pass this to their newborn infant. This is data from the CDC, and once again, and probably did not need me to put the red box around West Virginia there at the very top, but this is state estimates of hepatitis C among pregnant women, and really we have a spectacular burden. And in the middle of 2022, perinatal hepatitis C infection became a reportable condition here, and in that just half year, there were 11 confirmed cases among infants. So really a genuine problem. And here's data from our own Bureau for Public Health, another heat map. The darker the color, the worse the problem. And here you can see outlined in various shades of red what the rate of hepatitis C is per 1,000 deliveries. And you can see that in Mineral, Hampshire, and Nicholas counties, Hancock and Brooke really had the highest rates in the state, but many other counties weren't spared. And it's true for almost everything that I can think of that's related to our drug epidemic. The southern coal fields are always overrepresented. So let's stop for a second and talk about what the risk of vertical or mother-to-child transmission of hepatitis C actually is. So in pregnant women who only have hepatitis C, so hepatitis C monoinfection, a, uh, a, the overall risk is about 6%. Is based on studies, 17 studies that were reviewed by Benova in 2014. And the interesting thing was, of course, that maternal viral load, hepatitis C RNA levels, were directly correlated with the risk of transmission. So that rate was 11% once the maternal viral load was more than a million, and a million is a very more than a million is an extremely common viral load among people who have chronic hepatitis C. Of course, women who are antibody positive but do not have uh, any evidence of active viral replication represented by a positive RNA have no risk of transmission. That positive antibody just means they've been infected by hepatitis C, but had the good fortune to have an immune system that was capable of eliminating it. And so just antibody positivity alone does not confer any risk. Now, in women who have both HIV and hepatitis C, both of which, of course, you can get from injection drug use, the overall risk was almost double, so close to 11%. And the specific risk factors are prolonged rupture of membranes, so more than 6 hours, any kind of obstetric procedure or intrapartum event that results in the infant being exposed to maternal blood. So internal fetal monitoring or lacerations, and then, of course, maternal injection drug use is the big one. So we have thought for a long time that the risk of transmission was happening primarily at or shortly before delivery, but there's been some information recently in a small number of mother-infant pairs that suggests that the transmission may actually be happening earlier in gestation, somewhere between 25 and 36 weeks. And what this means is that intervention would have to be significantly prior to delivery for during pregnancy if it were going to make any difference. What is not associated with an increased risk of perinatal transmission of hep C is whether the delivery is vaginal or cesarean. This is different from HIV, another RNA virus, where vaginal delivery in the face of a viral load that's at least 1,000 copies has an enhanced risk of transmission, and also breastfeeding, again, different from HIV. So what happens to these babies? Well, most of these children are asymptomatic. If you draw their blood, they may have mild transaminase, AST, and ALT abnormalities. Infants that are born to moms with chronic hepatitis C can have both transient infection that winds up being spontaneously cleared, but they can also go on to chronic infection. And interestingly, and sadly, actually, a couple of studies that have followed patients for a decade or two after they acquired hepatitis C perinatally showed that about 10% have significant fibrosis and half of those have cirrhosis. So now we're talking about children who might be, say, 20 years old, and they have cirrhosis. This is not a good story. So there's been a great deal of discussion over the last several years about when should we test the baby. The prior standard was to do serology, meaning look for a hep C antibody at 18 months. And at 18 months, of course, because that's the point at which we expect the transmitted maternal antibodies to be gone. And there were reasons to do this, not least of which that PCR is expensive, and we can't treat a child until they're at least 3 years old anyway. So the argument was, what's the big problem with waiting till testing at 18 months? And the other argument was that let's find out early. Let's do an RNA PCR, find evidence of active viral replication. This is highly sensitive and specific. This will tell us which babies have the real possibility of going on to develop chronic hepatitis C. Now, it is possible that some of those children, of course, would spontaneously clear. And the other important part of this argument is that this is a way to identify babies who might be at risk of being lost to follow-up so that they can be, maintained in care and followed carefully. And then if they don't spontaneously clear, then be cured once they reach 3 years of age. So the current changes for infant testing are that perinatally exposed infants should receive an NAT as a nucleic acid test for RNA in that early period, 2 to 6 months after birth. And these are the children we worry might develop chronic hepatitis C, and a subset of them might go on to have liver fibrosis and even cirrhosis. If the infant never has a positive RNA result, then good. There's nothing further that we need to do. And then children who are older than that, 7 to 17 months, who had not previously been tested but could have had a perinatal exposure, should also be tested in the same format. And for the children who are at least 18 months old and perinatally exposed, we stick to the old guidelines of doing a hep C antibody test, but this time with reflex to RNA, and I'll come back to this in a few slides. So part of the problem with hepatitis C in pregnancy is not only the risk to the unborn child, but the fact that women who have chronic hepatitis C have worse obstetric outcomes, have more morbidity. And I'm going to show you 2 slides, and everything on here is less than 0.001 in terms of significance. So these are women who are primarily women who did not get prenatal care, who also smoke cigarettes, and who have Medicaid insurance, but who are married. And this is across the entire United States. This is not specific to West Virginia. And here on this slide, you see the obstetric and neonatal outcomes. And preterm birth, which is a real complication of chronic hepatitis C infection, was clearly, again, everything on this slide is statistically significant, but there in red, you see preterm birth at various points between less than 28 weeks and up to less than 37, as well as low birth weight, small for gestational age, and then for the newborn, a NICU admission and neonatal death are all significantly associated with maternal hepatitis C. So it's much more than just transmitting hepatitis C to the baby. It's also, a number of significant risks to the mother, related to obstetrical complications. The birth score, the West Virginia birth score, and here's the URL for it, was amended in February of 2020, and now includes, I know this is small, you have to trust me that it's inside the red oval, and now includes a checkbox for maternal hepatitis C, yes, no, unknown. And this is, in service of trying to ensure that we identify the babies who are potentially at risk. Now, the problem with that is that due to HIPAA, We cannot link the mother's medical record to the infant's, and so there's got to be a way to get this information to whoever's going to be the clinician for the infant, as opposed to whoever is attending the mother at delivery. So here's what I mentioned before. It's for hepatitis C. Ordering the correct test is the whole ball game. Actually, that's probably true for everything in medicine, but it's really true here. And that is because for many, many years, people have just had this hepatitis C antibody available to them. And you can, after exposure, C antibody in a month to up to 3 months after infection, and almost everybody will have developed antibody by 6 months. There's also rapid tests that can give you an antibody result in about 15 minutes. And once you have met this virus, this antibody is there for lifetime. And the problem with this is, if you don't do a confirmatory nucleic acid test like PCR, this is a meaningless test. It is useless for medical decision making because you can't differentiate who got exposed to hepatitis C and cleared it, and who got exposed to hepatitis C and now has chronic hepatitis C. And for that, you absolutely need this confirmatory test that detects active viral replication. So the most commonly used one is the RNA PCR, but there are other nucleic acid-based tests besides RNA PCR. And there's both a qualitative sort of yes-no test and a quantitative test that we refer to as the viral load. And the quantitative test will tell you how much hepatitis C is in a cubic milliliter of blood. And we can determine this as early as 2 to 3 weeks after infection, so way before people develop antibody. So the way to order the correct test is to order hepatitis C antibody with reflex to RNA PCR. I really wish that hospital labs and LabCorp and Quest would take the isolated hep C antibody test just off their list, because people persist in ordering that. And then, as I said, you can't use it. It doesn't tell you what you need to know. And the virtue of ordering it this way, as antibody with reflex to RNA PCR, is that if antibody is present, the lab automatically goes to the next step to check the PCR. And then you get a response from a single blood draw. Yes, my patient has chronic hepatitis C, or no, my patient does not. And this is wonderful because it avoids having to bring the patient back for another blood draw, which is sometimes very difficult anyway in people who have a significant history of injection drug use. And there is now, I don't know about its availability at specific sites in West Virginia, but just a few months ago, the FDA approved the first point of care test that can confirm the diagnosis of chronic hepatitis C through detecting RNA. And it can do this in about 60 minutes. Cepheid is the manufacturer. It works off a platform that many commercial labs and hospital labs already have. And then you have to order the specific software and reagents for hepatitis C. So this is a real, once this point of care test becomes more readily available in the community, this will enable us to be able to diagnose and talk about treatment in the same visit, which is wonderful because this is in general a patient population that often, you lose touch with. So let me present a case to you. This is a case that actually we just dealt with. So this is a young woman who began Mavorette, a combination therapy for hepatitis C. Just this past November 26th, she had a negative urine pregnancy test. A couple of weeks later, on December 9th, she be picked up at the pharmacy and began her second month of 2, because this is only an 8-week regimen, on December 20th. And then, because of symptoms, had a positive pregnancy test in early January. At that point, she had completed 6 of 8 weeks. and her viral load was checked, and it was actually already undetectable, which is frequently the case that people become have an undetectable viral load before the end of therapy. So let's take a step back here and talk about what, when in the course of things, there are FDA-approved treatments for hepatitis C. And you can see in this slide that there is no FDA-approved treatment during pregnancy, breastfeeding, or early infancy. Those are the FDA rules. But there's been a lot of debate about whether we should offer treatment for hepatitis C during pregnancy. First of all, treatment when it's successful is curative, unlike treatment for HIV and hepatitis B, which is just suppressive, but the virus is still there. And there's a lot of benefits that have been raised in favor of treating during pregnancy. One is that you can cure the mom during a time when she has got healthcare coverage and is engaged in healthcare and has significant motivation to protect her unborn baby. This also will reduce transmission in the community and reduce the associated morbidity of hepatitis C. And I already just showed you some of that morbidity that is obstetrical. And of course, there is definitely psychological benefit to curing somebody of a chronic viral disease. I think also, again, there is this significant reduction of hepatitis C associated pregnancy risk, like cholestasis of pregnancy and fetal growth restriction and preterm birth. And of course, you would reduce perinatal hepatitis C transmission. And on the risk side, we do have limited safety data. DAAs stands for direct acting antivirals. It's just the acronym shorthand for the modern antiviral therapy that we have for hepatitis C. And we do have limited data in this setting. There's been a couple of pharmacokinetic studies that show that it's well tolerated in women, that there's maybe a total of 22 or 23 women in those two studies. So if you turn to the guidelines for what they say about treatment during pregnancy, then the American College of Obstetricians and Gynecologists say don't treat during pregnancy. And this was updated by ACOG in September of 2023. And the American Association for the Study, the joint guidelines from the American Association for the Study of Liver Disease and the Infectious Disease Society of America, and it has an evolving consideration, and I'll show you that in the next slide. So this was published in August of 2020, and the ASLD-IDSA guidelines say, well, of course, ideally, we should be curing women before they become pregnant. No one would argue with that. They say that if you diagnose hepatitis C during a pregnancy, then, the woman should be counseled, and that counseling be aimed at determining when hepatitis C treatment would be best for that person. But what was new in August of 2020 was this statement, that treatment can now be considered during pregnancy on an individual basis after a patient-physician discussion about the potential risks and benefits. And this is based on a number of things. As I said, there have been a couple of phase 1, phase 2 studies that have shown that some of these drugs that have been tested are well tolerated during pregnancy. The chemical classes of these drugs, protease inhibitors and nucleoside analog inhibitors, are the same classes of drugs we've been using now for 30 years to prevent the vertical transmission of HIV. And, that has been reasonably well tolerated. And there are clinicians who have been offering this possibility to women. And on a case-by-case basis, there are women who have accepted this treatment. And so far, at least anecdotally, nothing terrible has happened. So it's a little bit more liberal than the ACOG guidelines. And I would say that I think that this really is a field that is an area that is in active evolution. And here's one of the studies that is starting to make an impact and probably will have a greater impact when it's completed. So the acronym is STORC, Safety, Tolerability, Outcomes of Sofosbuvir, Velpatasvir, which is Epclusa by trade name, in the treatment of chronic hep C during pregnancy. This is a multi-center study that started a few years ago now, and is aiming at enrolling 100 pregnant women. I think they're up to 30 something. I'll show you some data for the first 24 in a couple of slides. And here, to be in this study, in addition to having chronic hepatitis C, it has to be a singleton pregnancy, and treatment isn't started until the 26th week of pregnancy, so well after organogenesis has been completed. There are 6 sites here in the US and 1 in Canada. And there's actually a site at Marshall. And if you have patients you think would be interested, here's the name and email and phone number of the coordinator at Marshall. And the dose of Epclusa that is being used in this study is based on this prior pharmacokinetic work that I mentioned. There were a fair number of adverse events in the moms. The most common are the ones we anticipate when we treat with these modern DAAs. They're primarily GI, nausea, vomiting, headache, some fatigue. There were a total of 13 serious adverse events, but nothing was considered to be related to the medication. And none of the infant AEs were related to the medication. So it
Dr. Feinberg,
does.
can you go back one slide? I think we missed one for where you
Oh, okay.
froze.
Here it is.
Yeah. Yeah, if you could just go over that one and then thank you.
This one, is this where you want
Yes.
me to start?
Yeah.
So this slide shows the obstetrical outcomes in the first 24 patients. And you can see that there were 3 preterm births, which is a very common occurrence among women with chronic hepatitis C, but not a single case of the cholestasis of pregnancy. And then all of the women who have gotten to the time point for cure have been cured. That's par for the course. This is kind of the outcome you expect. And then there were no perinatal transmissions, but as I said before, at a 6% rate of vertical transmission, among 24 pregnancies, you wouldn't necessarily expect to see one. And then I don't need to go over this one though, do I, Chantry? This is the one I just,
Yeah, you can go ahead and skip that one.
okay, let's
Thank
go.
you.
So in this patient, the Mavorep was discontinued after 6 weeks, and the recommended further management was to repeat her RNA PCR, which is the test of cure, 12 weeks after stopping treatment. So we typically do the PCR test to assess cure 12 weeks after the patient swallows the last dose, and here she only swallowed 6 weeks out of 8. And so you can tell from the dates I gave you in the prior slides, this is still pending. So I can't give you an outcome, but hopefully by the time this series is over, we will maybe know that. Okay. So there are relatively new recommendations for preventing mother-to-child transmission. The background to this is that the elimination of Hep C is both a national and a state priority. Actually, every state in the nation has a hepatitis C elimination plan. And in the decade just recently finished in 2021, acute hepatitis C rates have just skyrocketed among reproductive aged women. We already talked about how we expect on average a 6% acquisition rate for vertical transmission. We can cure these children once they hit 3 years old. The real risk here is that many perinatally infected children are either not tested or linked to care. And because a fair number of them wind up in foster care, there's that kind of disconnect from the basic information that often happens in that setting. So based on these continued increases in hepatitis C, here's the new universal screening recommendations. So these came out a few years ago. Every adult, that's 18 and older, at least once in a lifetime. Every pregnant woman for every pregnancy. And then everyone with risk factors like injection drug use on a regular basis. So let's move on to hepatitis B. So we got the same problem for hepatitis B as we do for hepatitis C, which is Central Appalachia is a dangerous place for these infections. And again, all because of our drug epidemic. So here in the solid line, you see the spectacular increase in hepatitis B infections in just Kentucky, Tennessee, and West Virginia compared to the US as a whole. And in fact, our state, sadly, has had the highest rate of acute hepatitis B in this country for well over a decade, which is bad for us. And this is old data, but the point here is that acute and chronic hep B reports track together very nicely. And this is because, unlike hepatitis C, most people who get acute hep B get sick. A lot of people who get acute hepatitis C don't really, or may not be very symptomatic at all. So the most common cause of chronic hep B in highly endemic regions, which is the resource limited parts of the world, right? Africa, Asia, parts of South America. This is how people get hepatitis B. They get it from vertical transmission. And the vast majority of the infants who are born to moms who are surface antigen positive and E antigen positive become chronically infected. And like hepatitis C, there are more obstetric and other complications in pregnancy. And there is a higher mortality rate for moms or I shouldn't say moms, for pregnant women who have chronic hepatitis B. We here in the United States recommend antiviral therapy during pregnancy. We can't cure hepatitis B, but we can control it. And then the infant gets both vaccination and immune globulin, hepatitis B immune globulin. And those interventions are very successful in preventing perinatal hepatitis B infection. And the issue is you have to know what the mom's status is in order to offer her the antiviral therapy and in order to treat the baby. So we should screen all pregnant women, even if they've been previously vaccinated, because there are cases of vaccine failure. So the long-term outcome of hepatitis B vertical transmission is very different from that of hepatitis C. And although, like hep C, most of the infants are asymptomatic, they can become chronic carriers because being infected at birth means they don't have a very robust immune response. They don't make surface antibody. They don't have good cell-mediated responses. And 95% without intervention will go on to develop chronic disease with a 40% lifetime risk of cirrhosis or hepatocellular carcinoma. So really pretty terrible downstream events. So here's our guidelines for screening in pregnancy. This ACOG has added a few or amended what the CDC says. So they both agree that surface antigen should be checked at the first prenatal visit of every pregnancy, regardless of whether testing's been done before. The CDC and these guidelines go back to 2021, say retest at delivery if it increased risk. More specifically, ACOG says use the triple screen, surface antigen, surface antibody, and core antibody for all pregnant women who are older than 18, who don't have a documented negative triple screen result, or haven't completed a Hep B vaccine series, or who have ongoing known risk for Hep B, like injection drug use, regardless of whether they're vaccinated or not, or whether they've been tested or not. So the ACOG is very specific about testing for surface antigen, surface antibody, core antibody, whereas the CDC is still just talking about surface antigen. Okay, HIV. So, wow, again, driven so much by our drug epidemic. Uh, More than a third of the new diagnoses of HIV in West Virginia are among women, and they're primarily white. They're primarily, as you can see, between 25 and 44, which is clearly uh, uh, a childbearing capacity age. If you look at this slide in the second section, you can see that there's been a dramatic increase in the cases associated with injection drug use as the transmission risk. And then here we go, new diagnoses by age. And again, young women, women of childbearing age. This is the number of infants with known exposure to a maternal HIV infection. So you can see that since 2013, that number has at one point more than doubled, but it's still higher than it used to be. And the screening is recommended for all pregnant women and women who are particularly at high risk, people who are having unprotected sex with a positive HIV positive partner, or they are injecting drugs during pregnancy, should be rescreened in the third trimester. And we use the same combination treatment that we use for all patients with HIV in pregnancy, and this dramatically reduces transmission. So at the height of the AIDS epidemic in the 90s, we would have more than 1,000 babies born with HIV a year, and now it's, less than 5. And these are always to people who didn't get diagnosed, to moms who didn't get diagnosed with HIV, so that intervention wasn't possible. And women with viral loads less than 1,000 can deliver vaginally, but more than 1,000, we offer them C-sections to prevent perinatal transmission. And the current test, we call it the fourth generation test because it tests simultaneously for both antibodies and antigens to HIV. The older tests were just for antibodies. And this narrows the window period. So instead of waiting 6 to 10 weeks to see the development of antibody, you can see antigen in like 10 days, which is a tremendous improvement in our testing capacity. So here are the guidelines, both the CDC and the ACOG guidelines. There's a few things that are added by ACOG. All pregnant women should be screened first prenatal visit on an opt-out basis, just the way we screen everybody. And then you retest in the third trimester, preferably before 36 weeks. And here's the list of things that are considered at increased risk. And then ACOG specifies whether, including if the mom has had signs or symptoms of acute HIV, or if the mom's been incarcerated during this pregnancy, which is interesting. During labor and delivery, we do rapid testing. If the mother comes in without prenatal care, then we do a rapid test, which gives you an antibody result in 15 minutes. And again, for the infant, when we don't know the mother's HIV status, we do this rapid testing. Okay, I'm going to segue really quickly into the other STIs, syphilis, chlamydia, and gonorrhea. Syphilis is, just like everything else we've been talking about, is just undergoing spectacular increases, and we are now seeing congenital syphilis, which is truly frightening because it can be fatal. The guidelines for screening for syphilis in pregnancy is all pregnant individuals at the first visit and then universal rescreening during the third trimester and at birth. Instead of thinking about risk-based, just do it. For chlamydia and gonorrhea, it's all pregnant women who are less than 25 or 25 and older if they're at increased risk. And again, retesting in the third trimester for both categories. And then the last two bullets are about test of cure retesting. So I'll end just with a slide or two about barriers, obstacles to testing. So just want to remind everybody that harm reduction principles are important in this population. These are women who are largely have or are still injecting drugs. They need to be offered treatment for opioid use disorder, referral to syringe services. They need to get specific education and counseling about hepatitis C. But I would just mention to you a couple of the obstacles that we need to overcome. First of all, what I have found is that clinicians who've completed their training before about 2016 just may be unaware that we can cure Hep C in 8 to 12 weeks of once-a-day treatment, and that it has minimal side effects, and that we can control HIV to the extent that it can't be transmitted to another person, although it can't be cured, again, with minimal side effects. And that's because, if they trained earlier, they just unaware, or they know about older therapies that were far more toxic and problematic. There may be lack of awareness of the current federal screening guidelines, which is that everybody should be tested for HIV, Hep B, Hep C, at least once in a lifetime. People in primary care may not have easy access to expert guidance and may feel sort of at sea about this. It takes time to talk about this stuff. And so, primary care providers are really crunched to do what they need to do in limited visits. And there's ongoing confusion about how to interpret these hepatitis C blood tests, as I mentioned before. I mean, access to healthcare is a problem, especially the fact that the healthcare system remains extremely stigmatized about people who inject drugs. And this, in turn, is really discourages them from seeking care, except in the most significant emergency. So I put stigma in big capital letters because these are all stigmatizing diseases. Hep C, HIV, Hep B, substance use disorder, because of their association with drug use and sex. And sadly, here in West Virginia, even treatment of substance use disorder is stigmatized. And this is something we just really need to get over. So I offer to you that clinician education is a good way to do this. And here's a number of sources of great clinician education that's free, and all of it confers free continuing education. The ECHO programs, and you're here on an ECHO program now, and then the WV-HAMP and the WV-HIV-AMP programs, which you can access through the Rural Health Association. And just remember, there but for the grace of God probably go a lot of us. So let me stop there. Here's my email for future questions. And let's see if there are questions in the chat.